So if you want to drastically alter the appearance of someone's face, like specifically if you want to make a really long nose look significantly shorter, the most effective, visually striking thing a surgeon can do might be to never actually touch the tip of the nose at all.
Right, which sounds completely counterintuitive.
Yeah, exactly. Instead, they might take a surgical chisel to the dense bone right between the patient's eyes.
It's a massive optical illusion, really. It's just playing with light, shadow, and basic human perception.
Which is wild to think about.
It is, because we just assume aesthetic surgery is always this literal one-to-one translation, like you cut here to change here. But the human face is, well, it's a highly integrated architectural structure.
And that architecture is exactly what we're dissecting today. So welcome to today's deep dive. We are looking at a really fascinating chapter from the Open Access Atlas of Otolaryngology, Head and Neck Operative Surgery.
Yeah, specifically a chapter written by Dr. G.J. Trinity.
Right. And it focuses entirely on the osteocartilaginous fault.
Right.
Which that's just a medical term for the structural bridge of your nose, right?
Yeah.
The part made up of both bone and cartilage.
Exactly.
So our mission for this deep dive is to completely strip away that purely cosmetic view of rhinoplasty. What most of us casually just dismiss as a nose job.
Right.
And instead, we're going to reveal the intense biomechanical precision, the bizarrely specific sequence of steps, and honestly, the very real functional risks involved in reshaping this tiny part of the human face.
Because the stakes are just incredibly high here. I mean, the vault we were talking about isn't just sitting there looking pretty. It is a dynamic functioning valve.
Right, to regulate airflow to your lungs.
Exactly. And manipulating it requires a surgeon to act as a structural engineer, a carpenter, and a master of fluid dynamics all at once.
Wow. Okay, so to understand how a surgeon acts like a structural engineer, I think we have to look at their sequence of operations. Because if you were building or, say, remodeling a physical structure like a house, you follow a very strict logical sequence. You lay the foundation, you put the walls, and you put on the roof. You don't build the chimney before the foundation.
Obviously not, yeah.
So I just assumed a surgeon would start at the top of the nose with a solid bony bridge and then work their way down to the softer, delicate tip. But the text explicitly states that most rhinoplastic surgeons prefer to work on the osteocartilaginous fault after they have completely finished reconstructing the tip of the nose.
Yeah, and the logic there is, well, it's deeply tied to the body's natural violent inflammatory response to trauma.
Violent?
Oh, absolutely. When you manipulate the bony pyramid of the nose, which, let's be honest, often involves literally breaking and resetting facial bones, the body responds almost instantly.
I can imagine.
You get rapid edema, which is severe soft tissue swelling, and ecchymosis.
And that's the deep bruising and bleeding into the skin.
Yeah, exactly.
Okay, wait, let me push back on that logic for a second. You are saying they do the delicate tip first to avoid dealing with the swelling from the bone work.
Yes.
But if the bone work causes severe, rapid swelling anyway, won't that swelling just instantly travel down the face and completely distort the perfect tip they just spent an hour building? I mean, it seems like you just ruin your own work.
Well, that would happen unless you beat swelling to the punch.
Oh, really?
Yeah, it is a literal race against the body's trauma response. By doing the intricate tip surgery first, while the tissues are calm and completely undisordered, the surgeon gets the exact shape they want.
Okay.
Then they move up, do the aggressive bone work, and the absolute second they finish, they apply a heavy, rigid external nasal dressing and cast.
Ah, I see.
Yeah, that immediate compression locks the tissues down. It mechanically prevents the rapid influx of fluid and blood.
Oh, so they are basically putting a physical lid on the swelling before you even start.
Exactly. The compression physically leaves no room for the swelling to expand. And beyond just the swelling, there is a purely architectural reason for the sequence too. The tip of the nose is incredibly complex. It is made of dynamic, flexible cartilages that literally move when you speak or smile, but the bridge is solid and static.
Okay.
So it's geometrically much easier to establish the final, perfect anchor point of the flexible tip and then adapt the solid bridge to seamlessly meet it.
Rather than trying to force the delicate tip to conform to a preset bridge.
Exactly.
Okay, so you set your anchor point in the shifting sand and then build the solid road to meet it.
That's a great way to put it.
All right, so the tip is done. They move up to the bridge. And for a lot of people undergoing this surgery, the primary goal here is removing a dorsal hump. The bump on the bridge of the nose.
Right, very common request.
But getting rid of it isn't just taking a file and shaving down a piece of bone. This is where the engineering gets tricky, because that hump is a dual material problem.
It really is. The hump is a composite structure. The top half is solid nasal bone, sure, but the bottom half is actually the flexible upper lateral cartilages and the septal cartilage.
And what surprises most people is that in a typical hump, the cartilaginous portion is actually much larger and more prominent than the bony part.
Yeah, people always assume it's just a big chunk of bone.
Right. It's like mixed media woodworking. You can't just pick one tool and swipe it aggressively across the whole joint. You need a razor-sharp blade for the wood, which is the cartilage, and like a heavy grinder for the metal screws, which is the bone.
Exactly. But before they even touch that structural framework, they have to get the skin out of the way without ruining it. And they do this entirely from the inside of the nostril.
Which sounds impossible.
Right. Using an endonasal approach. They make highly specific incisions inside the nose. These are called intercartilaginous and transfixion incisions just to access the framework.
Wow.
But the critical mechanical step here is lifting the soft tissue covering the nose off the underlying bone and cartilage. And they have to do this in a very specific microscopic layer called the supraperitoneal surgical plane.
Okay, so we translate that into physical space. It's like peeling a stubborn price tag sticker off its cardboard backing without tearing the thin paper of the sticker itself. You have to find that exact microscopic layer of separation.
The physical mechanics are nearly identical. The sticker in this case is the soft tissue envelope, which includes the transverse nasal muscle and vital blood vessels.
Right.
And the backing is the perichondrium, which is the tough membrane covering the cartilage. If the surgeon stays perfectly in that microscopic separation plane, they avoid tearing the muscle. And more importantly, they avoid triggering a massive scarring response.
That makes sense.
Yeah, so once the tissue is safely lifted like a canopy, they slice the cartilaginous part of the hump with a scalpel. Then they use a surgical chisel called an osteotome to loosen the bony part, removing the entire hump on block.
And block meaning all together in one solid piece.
Exactly. And finally, they smooth the raw bone edges with a tungsten carbide rasp.
Okay, but if they fail to find that microscopic sticker backing, like if the surgeon's dissection is too rough and they tear into the soft tissue, the text says the body's healing process actually creates a permanent deformity.
It does. It leads to the first of three highly problematic outcomes, known collectively as the polybeak deformity.
Polybeak.
Yeah, in a polybeak, the nose takes on a curved, downward hooked appearance. It literally mimics a parrot's feet.
Oh, wow.
So if the surgeon is rough and violates that supraperitoneal plane, the traumatized soft tissues respond by laying down thick, heavy scar tissue right above the tip.
Which creates a physical bulge under the skin.
Exactly. We call that a soft tissue polybeak. The underlying bone and cartilage might be perfectly straight, but the scar tissue builds its own new hump.
Okay, so if scar tissue handles the soft tissue bulge, I'm guessing the hard materials themselves, bone and cartilage we talked about, they can cause a similar bulge if the surgeon gets the mixed media ratio wrong.
Right, and that is the cartilaginous polybeak. It's a mechanical framework error.
How does that happen?
Well, when a surgeon is chiseling bone and slicing cartilage, bone dust and blood can easily obscure their view. If they under-resect the cartilage, meaning they leave too much behind it, it protrudes.
Makes sense.
Conversely, if they over-resect the bony part of the hump, like sinking the top of the nose too low, the perfectly normal cartilage suddenly looks like a mountain peak in comparison. The ratio is totally ruined.
Right, you lower the valley too much, and the foothills suddenly look like the summit.
That's a perfect analogy.
But the text mentions a third type of polybeak, and honestly this one blew my mind because it proves how interconnected the entire face is. It's called relative polybeak, and it happens when the bridge of the nose is actually perfectly fine.
Yeah, the bridge is flawless, but the surgeon accidentally destroyed the structural foundation of the nasal tip during that very first phase of the surgery.
Wait, really? How?
To understand this, imagine the tip of your nose is supported by two tiny horseshoe-shaped pillars of cartilage. They're located at the very base of your nostrils, right between between the openings. These are the medial crura. They attach to the bottom edge of your central septum to literally hold the tip of your nose up in the air.
So they're the structural tent poles holding the tip up.
Yes. Now, if a surgeon makes a complete transfixion incision, meaning they cut too far down with their scalpel inside the nose, they completely sever those tent poles from the solid septum.
Oh no.
The tip of the nose immediately loses its structural support and droops downward toward the lip. When the tip falls, the perfectly straight bridge suddenly looks like a high curved peak relative to the collapsed tip.
That is crazy. A microscopic misplaced cut at the very bottom of the nose ruins the appearance of the very top. It is all incredibly integrated, which I guess raises a massive mechanical problem.
What's that?
So let's say we've successfully shaved down the hump and we avoided all these polypeaks. But removing that volume leaves a flat, open space at the top of the nose, like removing the peaked roof of an A-frame house. You are left with a flat, open ceiling looking straight down into the living room.
Right, the open roof deformity.
Yeah, the open roof deformity. How does a surgeon close that gap without the whole structure just collapsing inward?
Well, this is where we transition from the delicate shaving of cartilage to the deliberate controlled breaking of facial bones.
Oh boy.
Yeah. To close that open roof, the surgeon has to literally detach the structural sidewalls of the nose from the face and move them inward to meet in the middle. This requires osteotomies.
The deliberate breaking of bones in the middle of the face. That sounds chaotic. I mean, how do they ensure the bone goes exactly where they want in a clean line and doesn't just shatter inward like a broken windshield?
It's a fair question, but modern surgical refinements have turned a previously violent procedure into a highly controlled acoustic arc.
Acoustic arc.
Yeah. First, to prevent the area from becoming an absolute bloodbath when the bone breaks, they inject a local vasoconstrictive solution at least 15 minutes prior to the osteotomy.
Okay.
That 15-minute waiting period is non-negotiable. It forces the blood vessels to clamp down so tightly that the surgical field remains almost entirely bloodless.
Oh wow. So they temporarily restrict the blood flow just to buy themselves a clean visual field.
Exactly. Once the field is clear, they use microosteotomes. These are specialized chisels, sometimes only 2 or 3 millimeters wide.
That is tiny.
And surgeons will actually have the scrub nurse Sherman these tiny chisels right there in the operating room during the surgery to ensure the blade is microscopic in its precision. They gently tap these chisels along the bone to create a controlled fracture line.
But even with a sharp chisel, bone is brittle. Why doesn't it just buckle and fall into the nasal cavity?
Because of a vital anatomical structure called the periosteum.
The periosteum.
Yes, it's a thick fibrous sleeve of connective tissue that tightly wraps around all the bones in your body. In the past, surgeons would strip this sleeve away to see the bone better. Today, they leave both the external periosteum and the internal mucosal lining completely intact.
Okay, so it's like leaving thick, heavy wallpaper on both sides of a cracked plaster wall. Even if you take a sledgehammer and break the plaster underneath into pieces, the wallpaper holds all the broken shards tightly together in exactly the right shape, right? Allowing you to push the entire wall inward as one solid unit.
That is exactly what happens. The periosteum acts as an invisible internal splint, and the geometry of the chisel cuts has completely evolved to minimize trauma, too.
How so?
Surgeons used to execute a brutal transverse osteotomy. It was a totally horizontal cut, straight across the top of the nose to detach the bone. Now they rely on the natural physics of the skull.
Okay.
They make a medial oblique cut angling outward from the center, and a curved lateral cut coming up from the side. Where those two lines naturally intersect, the bone gently gives way. It completely eliminates the need for that highly traumatic horizontal break.
Wow. But geometry's unforgiving. If the angles of those cuts are even a millimeter off, the text outlines some pretty visceral mechanical failure.
Oh, absolutely.
If you're listening to this and you touch the bridge of your own nose, you can trace it upward until you feel the bone get incredibly thick, right between your eyebrows. This is the radix. What happens if the surgeon's chisel goes too high into that thick bone?
You trigger what is mechanically known as the rocker phenomenon.
The rocker phenomenon.
Yeah. As you move up toward the forehead, the bone changes from a thin, brittle plate to a dense, incredibly thick wedge. The crossover point of this surgical cut should never go higher than the intercanthal line, an imaginary horizontal line drawn between the inner corners of your eyes.
Because if you try to break that thick wedge,
You accidentally create a lever. If the cut goes too high into that dense upper bone, it acts as a fulcrum.
oh no.
When the surgeon pushes the bottom of the broken bone inward to narrow the nose, the thick top piece rocks outward in the opposite direction, violently protruding out into the skin between the eyes. It acts exactly like a seesaw.
That is, wow. You push the bottom in, the top kicks out, and you have a massive visible bump between their eyes. And what if they mess up the lateral cut along the side of the face?
That causes the staircase phenomenon.
Okay.
This is a geometric error. It happens when the lateral cut along the cheekbone is made too far medially, meaning too high at the side of the nose. When they push the bone inward to close the roof, the bottom edge doesn't sit flush with the cheek.
So what happens?
It creates a visible, palpable step-off, a literal staircase ridge running down the side of the nose under the skin.
It is a terrifying margin of error.
Yeah.
And this naturally pulls us right back to that thick bone at the top of the nose, the radix, which we mentioned at the very beginning of the show.
Right.
The radix dictates the nasofrontal angle, basically where the slope of the nose meets the forehead. And reading the biomechanics of this specific area, it fundamentally changes how you perceive human faces.
The radix really is the anchor of facial perception. The deepest depression of the radix is a specific point called the nation.
Yes.
What's fascinating about human optics is that changing the physical depth or the vertical position of this single depression completely alters the apparent length and forward projection of the entire nose, without the surgeon ever altering the physical length of the structure itself.
It's the visual equivalent of hanging a painting in a living room. You take the exact same painting, but you move the nail just 2 inches higher or lower on the wall, it completely changes the way the entire room feels.
Exactly.
It changes how high the ceiling looks, how big the couch below it feels. The painting hasn't changed size at all, but its relative position forces your brain to recalculate the dimensions of everything around it.
It is pure shadow play. If a patient wants their long nose to appear shorter, the surgeon doesn't necessarily have to aggressively cut away the tip or the bottom cartilages.
Right.
Instead, they can take a chisel or a glabella rasp and physically deepen that nasofacial groove between the eyes. By dropping the shadow of the nation deeper into the face, the visual line of the nose breaks earlier, making the whole structure look shorter.
And conversely, adding a tiny cartilage graft to fill in that depression raises the starting point, making a short nose appear elegantly long.
Precisely.
It's literally hacking the brain's visual processing. But the text notes a critical boundary here. While manipulating the thick bone of the radix is mostly about optical aesthetics, the moment we travel just an inch further down the face, moving out of the solid bone pyramid and back into the cartilaginous middle third of the nose, the stakes shift dramatically.
They absolutely do.
Because we bridge the gap between aesthetic shadow play and the fundamental human need to actually draw oxygen into lungs.
Right. This is where we transition from static architecture to dynamic function. The middle third of the nose is made of the upper lateral cartilages, which fuse with the central septum. These cartilages are not just shaped in the face, they are the flexible, load-bearing walls of your internal airway.
And there's a golden rule in the text about modifying these load-bearing walls. To actually physically shorten the nose, surgeons often have to resect or cut away the bottom edge of those upper lateral cartilages. But the rule dictates you must never resect more tissue from the lateral side walls than you do from the central septum.
Yes, never. To use your housing analogy, if you want an open concept living room, you might knock down a wall. Aesthetically, it looks bright and massive, sure, but if that was a load-bearing wall, the aesthetic improvement is completely irrelevant the moment a heavy winter wind blows and your roof caves in.
Exactly. So if a surgeon ignores that golden rule and aggressively trims those lateral cartilages to get a cute, highly sculpted tiny nose, what happens when the wind blows, or in this case when the patient breathes?
They induce a severe functional deformity called inspiratory collapse.
Inspiratory collapse.
Yeah, it relies on the Bernoulli principle of fluid dynamics. When you take a deep breath in, the rapid flow of air through the narrow nasal passage creates negative pressure. In a normal nose, the cartilages are stiff enough to withstand that pressure.
Okay.
But if the surgeon over-resected them, making them too thin and floppy, that negative pressure literally sucks the sidewalls of the nose inward. The airway physically collapses and seals shut under the force of the patient's own breath.
So they wake up with a visually flawless nose that acts like a vacuum-sealed plastic bag every time they try to inhale.
Exactly. It's a disaster.
So if they ruin the structural rigidity of that internal valve, or if a patient naturally has an airway angle smaller than the required 10 to 15 degrees, how do you rebuild a load-bearing wall inside a millimeter wide space?
You wedge the door open. Surgeons use what are called spreader grafts.
The spreader grafts.
Right. They harvest tiny, stiff, rectangular strips of cartilage, usually from deep inside the patient's own septum. They surgically wedge these strips precisely between the central septum and the collapsing lateral cartilages. This physically pushes the sidewalls outward, restoring the structural rigidity and permanently widening the internal valve so it literally cannot collapse under negative pressure.
It is brilliant, purely mechanical engineering.
Yeah.
But all of these rules about load-bearing walls and cartilage bring us to the most sobering section of the text: pediatric patients. Because if shaving a millimeter of cartilage off of an adult can collapse an airway, the biological stakes for operating on a growing child must be terrifying.
Oh, it's a massive risk.
The text references extensive studies, specifically pointing to the Verwoerd group, showing that operating on a child's cartilaginous vault can permanently stunt the growth of the midface.
Yeah, the research from the Verwoerd group is totally foundational here. They proved that the cartilaginous nasal septum isn't just a partition, it is the biological engine, like a pacemaker for the growth of the entire midface.
Okay.
As the septal cartilage grows and expands, it physically pushes and pulls the surrounding facial bones downward and forward.
It's the engine driving the train of facial bone.
Exactly. And interestingly, the study showed that manipulating the nasal bones in a child does not cause these severe growth anomalies.
Really? Just the cartilage?
Just the cartilage. It is strictly trauma to the growing cartilage that stunts development. If you aggressively cut into a child's septal cartilage, that midfacial growth engine stalls. The upper jaw may not develop fully, leading to severe underbites and flattened facial features as the child reaches adulthood.
Which logically leads to the ultimate pushback. If touching a child's cartilage carries a near certainty of stunting their facial growth, why would a surgeon ever agree to operate on a 10-year-old? Why not just wait until they're 18 and fully grown?
Well, because sometimes the alternative is worse. And the text highlights a really poignant clinical dilemma.
Okay.
It presents the case of a 10-year-old girl who suffered a severe post-traumatic septal deviation. Her nose was likely broken in an accident, and the cartilage healed so crookedly that her nasal airway was completely obstructed.
Oh, wow.
She could not breathe through her nose, which obviously affects sleep development and overall health. Furthermore, because her damaged cartilage was still growing, her nose was becoming progressively more twisted and deformed with each passing year.
So the engine was derailed, but it was still pushing the train forward, just in the wrong direction.
Precisely. So the surgeon is forced to weigh two incredibly heavy variables against each other. On one hand, you have the absolute medical necessity of restoring a child's airway, combined with the immense psychological benefit of preventing a severe worsening facial deformity during their most formative social years.
And on the other hand,
you have the scientifically proven risk of stunting the downward growth of their midface.
it's a surgical tightrope.
It requires immense restraint. The surgeon must execute the absolute minimum intervention necessary. They must straighten the septum just enough to restore the airway and normalize the appearance, while meticulously preserving as much of the intact, undamaged cartilage growth centers as physically possible, because they know that any unnecessary cut could alter the child's face for the rest of their life.
That reality completely reframes everything we have unpacked today.
Yeah.
We started this deep dive looking at the osteocartilaginous vault as, a sequence of mechanical puzzles.
Right.
We saw why surgeons race against time, fixing the tip first, before the violent swelling of the bonework distorts the tissues. We explored the mixed media nature of the hump and the microscopic precision required to find the supraperitoneal plane and avoid the thick scar tissue of a polybead deformity.
Yeah, and we examined the controlled acoustic art of osteotomies, utilizing the periosteum as an internal splint to safely fracture the skull, while carefully avoiding the levers and step-offs of the rocker and staircase phenomena.
We looked at the sheer optical illusion of the radix, manipulating shadows to change perceived length. And finally, we confronted the unforgiving physics of the functional cartilage, those load-bearing walls preventing inspiratory collapse, and the heavy biological responsibility of interacting with the mid-facial growth engine of a child.
It's a lot, and when you synthesize all of this, it leaves you with a really profound realization about our biology.
Definitely.
We casually view cosmetic changes as purely surface-level modifications, a quick fix to an isolated problem. But when you understand that shaving away a millimeter of cartilage can completely collapse a human airway, or that altering a tiny zone of tissue can permanently derail the entire growth trajectory of a human face, it forces a much broader question.
It really does.
How many other tiny, seemingly superficial elements in our own bodies, in our daily habits, or in the environments we build, are actually secretly acting as the invisible structural foundation for everything else?
The ultimate load-bearing walls hiding right in plain sight. It is certainly something to think about the next time you look in the mirror. Thank you for joining us on this deep dive into the extraordinary architecture of the human face. Until next time.